Thank you, RT, for that very kind introduction, and thank you for the opportunity to share the work that I've been doing building a program to treat resistant hypertension here in the cardiovascular division. And before I even begin, I really want to recognize Dr. Jennifer Cluett and Dr. Eric Secemsky that I've been working very closely with in this endeavor, and also Dr. Brett Carroll, who has been a mentor both in program building and just overall in shaping my career. And welcome to the applicants, a warm welcome to the applicants that are here today. So I'm going to talk about the state of hypertension in the US. Then I'm going to highlight some key components of hypertension care that I have worked very hard on, some of which have been surprising to me. And then I'm going to dive into novel therapies for hypertension. And I want to highlight today that hypertension is really having a moment right now. There haven't been novel therapies in hypertension for a number of years, and now we have both new classes of antihypertensive medications as well as procedural therapies. So I think it's a good time to capitalize on this momentum and a good time to build tools and infrastructure around hypertension care at the BI. And last, my colleague, Dr. Eric Secemsky, is going to focus on the research in renal denervation and our experience here at the BI. So these are a few points that are probably well known to this audience, but that I think are critically important. So hypertension is highly prevalent. So 48%, or essentially half, of US adults have hypertension. And now, really, most of these patients do not have their blood pressures under control, which is pretty shocking thinking about other endpoints we have in cardiology like LDL. It's almost 80% of these patients do not have controlled blood pressures. And interestingly, one study that looked at this found that 90% of patients with uncontrolled blood pressures have a source of usual health care. And many of these have insurance as well. So in terms of overall trends, blood pressure control was increasing for a long time in the United States, but then began to drop in the year 2013, 2014, and blood pressure control has actually been declining since this time. So hypertension really is a huge missed opportunity, and I think that it's a privilege to get to pay attention to it and bring everyone's attention to focus on hypertension today. So this is another trial that people are very familiar with, the SPRINT trial, but I like to highlight it just to make the point that treating blood pressure reduces heart outcomes and it reduces death. And this is one of the trials that drove our new hypertension guidelines, new being 2017. So in the SPRINT trial, patients were randomized to standard blood pressure lowering, and in this arm, they achieved a mean blood pressure of 134. And they were otherwise randomized to the intensive lowering arm, where a mean systolic of 121 was achieved. And even this difference in sort of the standard blood pressure lowering versus intensive lowering resulted in a significant decrease in heart outcomes. So the composite outcome was MI, ACS, stroke, heart failure, and CV death, and it resulted in decreased all-cause mortality. And then this is where the 2017 guidelines recommending goal blood pressures of systolic less than 130, diastolic less than 80 as a new target, which was a transition from the previous JNC guidelines. So why is there such a disconnect here? Why isn't blood pressure controlled, and why is there this gap? So there are a lot of reasons for this. Is really multifactorial. I'll just name a few, but increasing prevalence of cardiometabolic risk factors, lack of awareness by patients that they have hypertension. So this is the silent killer. That term continues to be very apt here. Patients often don't feel symptoms. They don't know they have it. And 39% of patients with uncontrolled blood pressures in one study were not aware of their diagnosis. Medication non-adherence, particularly among patients with resistant hypertension, is a major problem. And one meta-analysis found that 31% of those with resistant hypertension were non-adherent to their medications in various ways. Therapeutic inertia, so this is a term that sort of describes when physicians don't appropriately escalate medications when blood pressures are not at goal. And controlling blood pressure is really time intensive, and there are a lot of behavioral components, which are aspects of medicine that I think we struggle with more than others. Now, I really like to think about the Eisenhower matrix when it comes to hypertension. This is a task prioritization framework. And so this is a general framework that helps us to achieve what we want to achieve in life. So you divide your tasks into urgent and non-urgent tasks, important and not important tasks. And one thing that came out of the Eisenhower matrix research is that tasks that are important but not urgent really don't get done very well. And unfortunately, hypertension really falls into this box. It's extremely important. It's not urgent. And overall, those are tasks that are challenging for humans to do. And the advice is you have to schedule those tasks. You have to recognize and schedule those tasks, making hard deadlines. So that's kind of the landscape of hypertension in the US. Now I'm going to talk a bit about the landscape of hypertension care at the BI. So I'm really standing on the shoulders of giants here. There's been a lot of incredible work in hypertension before I started my work in resistant hypertension. So I want to recognize Dr. Jennifer Cluett, who very literally put hypertension on the map and made the BI an AHA certified hypertension center, among many other accomplishments over her last more than 10 years of working in hypertension at the BI. Dr. Stephen Juracek is an internist and R01 funded researcher who is the director of hypertension research at HCA. Dr. Murray Middleman in the lower left corner is instrumental in research at the BI, helps to run the T32 program, is a professor of epidemiology at the Harvard School of Public Health, and in hypertension started and essentially runs the 24-hour ambulatory blood pressure monitoring program, which is critical to hypertension. And then Ann Shea, RN, in the lower right corner, has been working in hypertension for over 30 years and has really been instrumental in program building here over that time. So I'm looking to really come into a nice infrastructure of components of hypertension care. And so again, my focus has really been on resistant and refractory hypertension and trying to build a set of tools and localize a set of tools to help to get these patients to goal and to treat these patients. And I'm going to just highlight a few of the key elements that I think are critical with this population and hypertension at large. And those are obtaining accurate blood pressure data, having infrastructure to evaluate for secondary causes of hypertension, identifying an algorithmic approach to medical management to use in your practice, and then bringing novel therapies to these patients, particularly those patients with true resistant hypertension. And I'm going to present a case to illustrate some of these components. So this is one of the first patients I saw as an attending here in the complex hypertension clinic. She's a 70-year-old woman with resistant hypertension. She was actually diagnosed at the age of 8 and has had, her life has sort of been dominated by her hypertension and the treatments for hypertension. So when she saw me, she had very labile pressures, highs up to 200, and then dramatic symptomatic drops in blood pressure. She was on a complex and time-intensive medication regimen, which required her to take her blood pressures several times a day and take hydralazine in response to various blood pressure parameters. And then she really had a low quality of life because she had significant intolerances even to the medications that she was on. So for example, she had to reduce her driving considerably because of hypotensive episodes. For example, she would fall asleep after taking her morning dose of clonidine tablet. So at her first visit with me, she was on clonidine tablets twice a day, hydralazine, hydrochlorothiazide, nifedipine, olmesartan. And then below her regimen, you see this long list of medication intolerances. Now, other than being diagnosed at age 8, this is, I would say, a pretty usual profile for the patients that I'm seeing. Many of them come with lots of allergies and intolerances to medications, as well as other issues to sort out. So I'm going to highlight the key components of hypertension care that I was able to apply to this patient. So first of all, having accurate blood pressure data, and I kind of struggled with whether to include this one because it's not very glamorous, but it turns out that having accurate blood pressure data is absolutely fundamental to treating patients with hypertension. And it is not easy because it is time intensive and because office blood pressures are notably inaccurate in many situations. So I included this chart on the right. It just shows a variety of factors that can alter blood pressures. So your cuff is too small, it's too big. They say it can alter it by a range of 10 to 40 millimeters of mercury. Patient is talking. And I think overall it's hard for to sort of build in the bandwidth to have a rest period for a patient. Make sure that they, take off their shirt if they have a long sleeve shirt. Make sure they aren't talking to whomever is taking the blood pressure or whomever is with them. Empty bladder. There are so many components that it just becomes sort of not practical to obtain accurate office blood pressures, which I think is a huge barrier to care. So you really have to get accurate data. And there are a few ways to do this. So because of Dr. Jennifer Cluid, who I mentioned earlier, I was able to build in automated office blood pressure devices into my clinic. So this is a device where with one touch of a button, it sets off a 10-minute cascade of checking blood pressures with an imposed rest period and no provider in the room. And so this helps to at least eliminate some of the challenges associated with standard office cuff. So I use this regularly, and actually Jen installed these AOBP machines in all of the primary clinics at HCA. There's 24-hour ambulatory blood pressure monitoring, which I mentioned that Murray really built up that program, which is particularly important for nocturnal hypertension, very labile pressures, concern for overtreatment. But of course, that's sort of a one-time measurement. So limited in terms of longitudinal management. So in the lower left corner, this is a figure from, I think, a really unique study that compared home blood pressures with office blood pressures in 24-hour ambulatory monitoring. And they found that if done correctly, home blood pressures were actually the most reliable and correlated the best with left ventricular mass index. So home blood pressures are what I try to use. This is a time-intensive process. It takes counseling of patients on techniques and a number of factors, but really you need the infrastructure and the ability to have patients take their home blood pressures and use those to monitor pressures over time and to titrate medications. So to move into sort of the next important detail, which is pharmacological treatment of resistant hypertension. So there are some key principles here that I want to highlight. So first of all, you want to start by maximizing first-line antihypertensives with complementary mechanisms of action to really achieve synergy. So the first-line antihypertensives, thiazides, ACE and ARB, and calcium channel blocker are synergistic when used together. It's really important to get all three of those on board in resistant hypertension and maximize the doses. You want to use best-in-class medications. So for example, chlorthalidone is more potent than hydrochlorothiazide. It's longer acting. So getting patients on best-in-class medications. Another example of that is valsartan. It's more potent than losartan. Losartan is the most commonly used ARB by far, and it's really not as good. It's not as potent. It's not as long acting. You get a potency bump with a switch to valsartan. Consider Entresto, which shows a blood pressure drop relative to valsartan in resistant hypertension, where you can get it covered. You can use potassium binders to kind of facilitate the use of some of these agents. You really want to use strategies that promote patient adherence, since we talked about non-adherence being such an issue. So long-acting medications, combo tabs when possible. And so after you optimize the diuretic, combine ACE and ARB and calcium channel blocker, get them on best in class, then your fourth line agent is going to be a mineralocorticoid antagonist supported by the ASCOT trial. Can use eplerenone if gynecomastia develops. Then your fifth line is beta blocker. Consider using long-acting carvedilol phosphate, which is just taken once a day if you're able to get it covered by insurance. And then last at the bottom, agents that I end up using a lot, and so I think is worth mentioning. Clonidine patch is far superior to clonidine tablets because it reduces CNS and other side effects, and it's long-acting, and it really promotes adherence. So I actually use clonidine patches quite a bit in resistant patients who are not controlled by the drugs mentioned above this. There's guanfacine and there's minoxidil, all of which are long-acting medications where you don't have to get them on hydralazine. And they're better for sort of promoting patient adherence. So going back to our case, the medication changes that we made converted her from clonidine tablets over to patches. She required 2 patches, which you can do with clonidine. Converted her nifedipine over to felodipine, started spironolactone, up-titrated. So we're able to achieve blood pressure control in this patient by just sort of implementing these basic principles, even with all of her medication intolerances. Now, in parallel to this, she underwent a workup for secondary causes. And I really want to highlight this because I think overall, the general impression is that these are rare. And really, they're not rare, especially in resistant hypertension. They're actually very common. So the big 3 here are renovascular hypertension, primary aldosteronism, which I'm going to pay particular attention to today, and obstructive sleep apnea. You really want to screen all resistant patients for primary aldo and obstructive sleep apnea, and then those that are truly resistant to medications for renovascular hypertension. So just diving into primary aldosteronism a little bit, because I think it's super important in hypertension and in cardiovascular disease overall. So it's highly prevalent, up to 20% in resistant hypertension. Some reports have published up to 25% prevalent and up to 25% of resistant hypertension. Screening rates for PA are far below guideline-based recommendations, so less than 2% even of the sickest population are screened for this condition. And really, it's not a binary diagnosis. It's not that you either have it or don't have it. This exists on a continuum. And so why is this important? I think especially for cardiologists, it's notable that patients with primary aldosteronism have more cardiovascular events than patients with essential hypertension. So this is a study where patients with PA treated with MRAs were compared with matched patients with essential hypertension. So treated patients with PA compared with patients with essential hypertension with matched blood pressures and an attempt to match comorbidities as well. And they looked at cardiovascular outcomes and saw that there really was a significantly higher incidence of hard cardiovascular outcomes in patients with PA. So I think this is something that we should overall pay a lot more attention to within cardiology. And again, thinking about it in the context of something like LDL, where we have hard numbers and we hold ourselves really accountable to treating to hard LDL targets. I think that PA should really be the same in seeing these data and seeing the increased rates of cardiovascular events. I think we're going to watch this evolve over time. So of course, treating patients with targeted MRA therapy is a good reason to screen for PA, but you also want to identify patients that may lateralize and benefit from surgery, and patients that potentially need more advanced imaging to look for adenomas. So diagnosing and treating PA, it's highly complex, and there are a lot of recommendations for holding medications at a lot of steps along the way. And I think one really clear clinical challenge here is, as the clinician, you have to try to understand how much of a patient's hypertension is being driven by that PA. This is something I didn't appreciate until seeing a lot of these patients. And so I think as an overall recommendation, screen patients with resistant hypertension for PA, and I screen them on all medications because it's otherwise extremely logistically challenging, and then interpret the results of those tests within the context of the medications that those patients are on. So it requires a lot of infrastructure to actually triage these patients. And if you test for PA, you will find it, as I have seen. And so this was really driven by Jen Cluett as well, but we've developed a multidisciplinary adrenal case conference that occurs biweekly, and we discuss these cases with endocrinology, endocrine surgery, and cardiology, internal medicine to really make the best decisions for these patients. I'll kind of zip through the rest of the slides, but renovascular hypertension, I just want to mention as an important secondary cause, and something that I think has a really nice union with the vascular medicine that we have built up at the BI as well. And of course, Eric as a peripheral interventionalist, this is also a complex decision-making because renal artery stenosis and renovascular hypertension are distinct, and you really have to decide which patients with renal artery stenosis actually have renovascular hypertension, which is something that our clinic can help with. So our patient ended up screening positive for primary aldosteronism with an aldo of 21 and a renin of 0.74, ratio of 28. But then she underwent saline suppression testing, which was negative. And I just want to give a big shout out to the CDAC, Liz Bridger, Lynn Macklinson, and Mike Gavin for helping me to set up a saline suppression infusion protocol in the CDAC to help to triage these patients. And she did have genetic testing, which is pending.
And I'm so sorry to interrupt. Because the interviewees have started 8:50. Do you mind wrapping up, and we'll just hand it over to Eric to speak for a few minutes?
Yes, yes. And I'm basically wrapping up, and just to say that our patient ended up undergoing renal denervation and had a really successful result with that as well. And we were able to down titrate her medications further. And I will let Eric jump in. Thank you.
Great, thanks, Anna. We're going to switch over here real quick, and I'll get everybody to their interviews on time. So I just want to show this very complicated slide in a very short amount of time, which makes total sense for everyone. But the highlight here is not to read the details, but to understand the concept here. And we've understood for a while that sustained increase in sympathetic activity is a primary driver of resistant hypertension. In particular, we know that there is catecholamine spillover that really challenges the cardiovascular system. And the problem with sympathetic overactivity is that it's fairly complicated and resistant to medical therapy alone. And this is really why alternative treatments are necessary in the toolbox for treating hypertension. So, the role of renal denervation really kind of came out of surgical sympathectomy. And this is data now you can see from 1948, before antihypertensive medications were available. And the only really intervention for patients who had resistant hypertension was bed rest. And so they'd give patients bed rest and barbiturates, and that's how you controlled blood pressure until there was a recognition that maybe clipping, surgically removing the sympathetic chain, can reduce blood pressure, and it can be done safely. So the kidneys can still function without compromise, even though there is a almost complete disruption of sympathetic activity. Now, obviously, this worked really well for blood pressure management, but it's a morbid procedure, wasn't going to be scalable. And what happened over time was the introduction of medications. And we can see from 1967 on, we now have over 40 different antihypertensives on the shelf to use for our patients. Now, catheter-based renal denervation became a concept and then a product being tested both in the US and abroad in the 2000s. We had been monitoring this closely, and right around 2015, there was a failed study called Hypertension 3 that really was challenging the whole field. And it wasn't that renal denervation didn't work, it was that it was equivalent results in the sham control arm, where patients reintroduced medical therapy and ended up getting the same reduction in blood pressure at the primary endpoint. So there's been a complete redesign of these trials, and this is really, we as a program started investing into the renal denervation market, was understanding that we could design trials better. We had some newer technology, and we started seeing early data demonstrating, again, benefits of renal denervation that outweighed a sham procedure. Again, you can look on the left here. This is Simplicity Hypertension 3, and this was the failed trial. And you can see that reduction in the sham arm that should have gotten no real significant blood pressure reduction, but ended up having nearly a 5-point reduction. And now with new technology and two different platforms, there's now up to a 9-point absolute reduction in blood pressure with renal denervation. And you can see that the intergroup differences around 5 to 7 millimeters of mercury. The other interesting part about renal denervation being a one-time procedure that takes under, really about an hour, is you can get a persistent benefit out through 3 years. So we can see here 24-hour systolic blood pressure and office systolic blood pressure between renal denervation and those in the control arm were really sustained out to 3 years. And we actually have data now, because this has been approved in Europe for about 10 years, that it's maximized even at 5 years and beyond. And some of the growth in the blood pressure changes occur at 1 year and beyond, even though our primary endpoints are shorter term, just by design for the clinical trials. The other thing that's really interesting about renal denervation is that the safety parameters of this procedure are quite intact. There's a big concern about, in particular, renal artery stenosis occurring late after treatment. And really, there has not been any significant demonstration of this. And if anything, we've seen renal function stabilize and decline less than what would be expected in an aged controlled cohort. So there are some probably renal benefits we have underappreciated that are outside of hypertension control, and no significant safety events. And because of this, in November of 2023, 2 renal denervation devices were approved back to back, one by Medtronic, which is the one we are using right now at the Beth Israel, and the other one by Recor Medical, which was a startup device company. And it's interesting, we have a lot to learn. There are non-responders in this treatment paradigm that need to be identified, and up to 1/3 may not have a significant blood pressure response. Nonetheless, there's a very broad indication being applied with this therapy in the US right now. This is from the label, just demonstrating that this therapy can be used with adjunctive treatment in patients with hypertension and whom lifestyle modifications and antihypertensive medications do not adequately control blood pressure. So we have a very safe procedure. It tends to be durable. It can be widely applied, but our biggest risk right now is not being able to identify who may respond and who may not. And we did a recent analysis looking at applying these indications to the broad hypertension population, and this can result in up to 12 million patients being treated and not having a significant blood pressure change. Now, again, we were involved in this very early. We are a site for one of their trials. We did one of the first commercial cases in the country. Killian McCarthy here in the picture with me on the right, it was one of our interventional fellows who's now in faculty down in North Carolina. And we've done about 10% of all commercial cases to date, 17 overall. And I'll show you in a moment our experience. Of note, and Anna really highlighted this, and Anna is the pipeline for the renal denervation program. Everyone sees Anna first. Anna spends at least 4 to 6 visits trying to optimize medical therapy. And after shared decision-making and a discussion of alternative treatment options, they're referred for renal denervation. You can see here that we really are taking care of high-risk patients. Many of them are on clonidine, 3 or more meds, but we're doing this safely with procedures lasting less than 9 minutes and no procedural complications to date. We have a registry that we launched, and we want to highlight our team, including Christian Maywell, our vascular fellow, Emily Crawford, a medicine resident, as well as our team at the Smith Center, Carrie Hannigan and Izzy Lockhart. And we have now 10 sites outside of ours who are going to be participating in the only prospective independent renal denervation registry. And overall, our experience has been remarkable. At 8 subjects who were treated at 6 months, we found a 24/10 reduction in office blood pressure, a 16/9 point reduction in the AOBP, that automated blood pressure. But we've seen some variability, and you can see right below that, about 62% of patients had more than 5 millimeter drop, but again, about 33% had a minimal drop. So back to our case, when we did AOBP on that same patient, she had an average blood pressure of 145/82 on a pretty complicated medical regimen, although Anna made that medical regimen much easier. And after renal denervation, we were able to get her off 2 meds. Her blood pressure is now down on AOBP to 126/72. And some of her off-target symptoms, including somnolence and fear of driving, have now resolved. So she's been incredibly happy with her result, as have we. And this is a great example of a responder who really has a meaningful change in their overall care. We have a lot going on in this space, and we're excited to get everyone on this call involved, both those at BI and also our future applicants. We have biomarker studies. We are doing a trial for atrial fibrillation. We're looking at multi-vessel renal denervation with hepatic artery denervation for diabetes management. We're looking into pulmonary artery denervation and also used for ventricular tachycardia and aortic aneurysm. So much to come in this field. This is a nascent space, as you can tell, and we're excited to be pioneers here and leading the way across the U.S. So we hope everyone have a wonderful interview today. These are just some of our trainees now who've worked with our program specifically in hypertension. This is a twice or triple the size if you include people in our research program in the Smith Center. And we can't wait to meet everyone on the call today, learn a little bit more about you, and show you what else we're doing here at the Beth Israel. So thank you very much.
Thank you so much to Dr. Secemsky and Krawisz. Really wonderful presentation. I'm sorry we had to fit it into only half an hour, but very much enjoyed it. I'm sure for those who have questions, they would be happy to answer them via email. So we'll let everyone get to their interviews. Thank you very much and good luck with the day.